So for today, our top 10 will be neuromuscular emergencies in toxicology. So let's do that. The number one is the Dutch GBS, Guillain-Barré Syndrome. This is an old study, see, 1992, and PIRAVIG, IVIG, Lancet 1997. It just shows you that we're using data from a long time ago for common diseases that we see almost every week in the ICU. Guillain-Barré syndrome, IVIG is equivalent to Plex, simpler and safer. Steroids are harmful. So they looked at severe GBS patients unable to walk, 150 patients, PIRAVIG 241, and IVIG was compared to plasmapheresis 4 to 6 sessions, and 53% improved at 4 weeks versus plasmapheresis 34% improved at 4 weeks. So the improvement was IVIG was definitely better, faster, equal efficacy, no IV access issues. Steroids consistently negative may worsen GBS. Multiple randomized controlled trials. The mortality 5%, residual deficits 20%. Most recover fully, but this is not a benign disease. Autonomic instability in 70%. So the GBS autonomic instability, 70% of patients have autonomic dysfunction, blood pressure swings, bradycardia, ileus, urinary retention. So you avoid long-acting antihypertensives. So IVIG and Plex combined. So that was the PIRAVIG 1997 showed that combining IVIG and Plex had no additional benefit over either alone. So you pick one. IVIG is preferred in practice. The only contraindication is IgA deficiency, because then you have a risk of anaphylaxis. So you should check IgA before the dosing. And the dose of IVIG is 0.4 grams per kilogram for 5 days. And that is the gold standard. Plex equivalent, but more complex. No steroids, which are consistently harmful. And remember the autonomic instability in 70%. You monitor the vital capacity and NIF daily. We're going to take a look at the 20, 30, and 40 rule. When it comes to myasthenia gravis, the next trial, Wolf et al., New England Journal of Medicine, 2016. This is the first randomized control trial after 75 years in terms of myasthenia gravis. Thymectomy improves MG without thymoma, 67% versus 47%. Minimal manifestations, less prednisone. So you look at non-thymomatous generalized myasthenia gravis, patients that have acetylcholine receptor antibody positive. And if they had thymectomy and prednisone versus just prednisone alone, minimal manifestations, still 67% versus 47%. So that is pretty remarkable. They had less manifestations. So, and every patient with generalized non-thymomatous myasthenia gravis should be referred for a thymectomy discussion. And what is this QMG? That's the quantified myasthenia gravis score. And 2.3 would be clinical improvement threshold, and less negative 2.85 exceeds this. Prednisone dose, so you should know at least what that is, a QMG score of negative 2.85 versus prednisone alone. Prednisone dose significantly lower with thymectomy, less steroid exposure. So in the MG crisis management, you hold pyridostigmine during the crisis, which can worsen secretions, IVIG over 5 days, or you give Plex times 5 sessions, unlike the previous Guillain-Barré syndrome where we said the IVIG was better than Plex. It seems like they could be either or here. No succinylcholine resistance. You need 3 times the dose. Or you use rocuronium at lower doses. That's if you intubate somebody. Precipitants, triggers, includes quinolones, aminoglycosides, magnesium beta blockers, and high-dose steroids, iodinated contrast. Thymectomy improves all outcomes in non-thymomatous myasthenia gravis. It gives you, 67% will have minimal manifestations if you have thymectomy. And once again, in myasthenia crisis, you hold the pyridostigmine. You give IVIG or Plex. You use rocuronium at lower doses and not succinylcholine. So what is this 20 to 30, 20, 30, 40 rule? This is Lawn Archives of Neurology 2001 and Shar Critical Care Medicine 2003. So they looked at 114 patients, and the Shar looked at 64 patients, and the 20, 30, 40 rule had a sensitivity of greater than 90% for intubation in neuromuscular junction failure. So we're looking at both GBS and MG. So forced vital capacity, hold on one second. Forced vital capacity less than 20 cc's per kilogram, MIP less than -30, MEP less than 40, or a 30% trend below. So that's the 20, 30, 40 rule. That's both the Lawn and Shar. We're looking at 2001 and 2003 studies. So then you look at the differentiation. How do we know the difference between Guillain-Barré syndrome and myasthenia gravis? So Guillain-Barré syndrome will have ascending flaccid weakness, legs first. Areflexia is the big one. And sensory-wise, you'll have tingling, pain, dysesthesias. CSF, of course, you have increased protein, white count normal, that's albumino, cytological dissociation. It's IVIG or Plex. Remember, IVIG was better than Plex in that trial we just looked at. No steroids, no succinylcholine, whereas myasthenia gravis is fatigable, ocular, bulbar weakness, proximal, normal to mildly decreased reflexes, but not lost. No sensory stuff. It's just purely motor. And acetylcholine receptor antibody positive 85%, and then the MuSK was 10%. It's IVIG or Plex, and you hold pyridostigmine during the crisis. So once again, the 20, 30, 40 rule you should know. Trend beats the absolute from baseline, 30% trend down. That would be intubate now. And the GBS ascending areflexia, whereas myasthenia gravis is fatigable, no sensory stuff, and both you should use rocuronium at lower doses in myasthenia. So if, let's say, you used 50, you would use 25 for intubation, let's say. No succinylcholine in both. So now the next one we're going to look at is alcohol withdrawal, because now we're going to get into the toxicology section. So the CIWA protocol back in 1989, Sullivan, we're looking at also Tidwell in Tidwell phenobarbital randomized controlled trial, and the Rosenson 2013. So these are the key discussions with CIWA. Guided benzodiazepines and phenobarbital cut ICU admissions 8% versus 25%. So you have 10 items. Here you have nausea, vomiting, tremor, sweats, anxiety, agitation. So scores less than 8, you monitor. 8 to 15, you give Ativan 1 to 2 PRN. If it's greater than 16, as we had a patient yesterday, ICU, and you give aggressive benzodiazepines. So phenobarb 10 milligram per kilogram IV cuts the ICU admissions 8% versus 25%. So it dropped it from 25% to 8%. And you should give thiamine before glucose. So basically what you want to do is you want to get a scoring system of the CIWA alcohol withdrawal, maximum 67 points. Remember, it guides the benzodiazepine dosing. And then phenobarb the loading dose cuts that's the Rosenson 2013 trial that cuts the ICU admissions from 25 to 8%. And you want to give, for refractory delirium tremens, you're going to use phenobarbital, maybe propofol, and you have to replete magnesium for all patients. Okay, so these are the criteria for the CIWA protocol. You could see here, and you just basically fill it out in terms of whether there are none, there are moderate or severe symptoms. Next one is the King's College 1990 SNAP trial 2014, but acetaminophen plus NAC plus King's College criteria. It's the most preventable liver failure. So let's look at NAC within 8 hours. It gives you near complete hepatoprotection. And then the SNAP is a 2-bag NAC, cut the reactions 5% versus 21%. So people have heard of the King's College APAP-induced acute liver failure 310 and the modified 2-bag NAC randomized controlled trial after it in 2014. So if you have less than 8 hours and you give NAC, that's the single most sensitive window in toxicology, 8-hour rule, and you don't wait for a level before the starting. The 2-bag is 200 milligrams per kilogram over 4 hours, then 100 milligrams per kilogram over 16 hours. Same efficacy, far fewer reactions. So that would be 5% versus 21%. So it used to be 3 bags, and now we use 2 bags of the NAC. And then the Rumack nomogram that everybody has, actually Tylenol gives it out under their website. It's 4 hours post-ingestion. You plot the level, treat if it's above the line. If it's less than 4 hours, you wait. If greater than 8 hours or unknown time, you treat empirically, regardless of level. The King's College criteria, transplant referral if your pH is less than 7.3, regardless of every other criteria. Otherwise, creatinine greater than 3.4, your INR greater than 6.5, encephalopathy. And the NAC protocol, which is now 2 bags, would be bag 1, 200 milligrams per kilogram over 4 hours. And then the bag 2 would be 100 milligrams over kilogram IV over 16 hours. The total would be 300 milligrams per kilogram over 20 hours. And if greater than 24 hours late, unknown time, you give the NAC regardless. Pregnancy, NAC is safe. You stop when the encephalopathy is resolved and the ALT is normal. So how does the NAC work? It replenishes glutathione, scavenges NAPQI. It works in all stages, including late. Never delay the NAC, waiting for a level. Late presentation, you give empiric NAC regardless of the serum level. So NAC within 8 hours, it's near complete protection. 2-bag NAC versus the 3-bag, 5 versus 21% anaphylaxis in the King's College. pH less than 7.3 or creatinine greater than 3.4, PT INR greater than 6.5. You're going to go to transplant, and those are the key points. Now, TCA overdose is another one we see. We used to see much more common. Now it's much less, so we won't spend too much time on this one. Old trial, 1986. Basically, you look at the QRS. If it's greater than 100, give bicarb immediately. Target pH 7.5 to 7.55. So the TCA toxicity would be sodium channel blockade, potassium blockade, anticholinergic. Of course, this is mechanistic, and there wasn't a randomized trial. But if the QRS is greater than 100, you give benzodiazepines. And if the QRS is greater than 160, you give bicarb emergently, and you would give it 1 to 2 milliequivalents per kilogram. Benzodiazepines only for seizures. You would not give phenytoin. They're absolutely contraindicated in TCA seizures. So things like Ativan would be what you would give. And you wouldn't give physostigmine. It can cause lethal bradycardia. even though it would reverse the anticholinergic effects, it would cause lethal bradycardia. So the triple threat is the sodium channel blockade, QRS widening, VTAC, VFib, but you could also have potassium channel blockade, which gives you torsade, and anticholinergic, which gives you the anticholinergic syndrome. So TCA overdose is the most dangerous overdose. Intralipid you use when there's refractory cardiovascular collapse despite the bicarb. Also works for calcium channel blocker and beta blocker overdoses. So TCA QRS greater than 100, sodium bicarb immediately, target pH 7.45, 7.55. Seizures, you give benzos only, no phenytoin, and never physostigmine, lipid emulsion for refractory collapse. Okay. Next, overdose toxicity is Annals of Emergency Medicine 2011. And case series, there's again no randomized control trial. No randomized control trial exists. It's a calcium channel blocker, beta blocker shock, high dose insulin first, 1 unit per kilogram bolus, and then a 1 unit per kilogram per hour plus a dextrose strip. Cardiomyocytes cannot use fatty acids. They switch to glucose dependence. So insulin bypasses the blocked receptor and directly stimulates cardiac glucose uptake and improves the inotropy. So vasodilation of coronary arteries. Why is it that insulin works? And that's the reason why. So it bypasses the blocked receptor and directly stimulates the cardiac glucose uptake. So these stepwise, you give high dose insulin, high intensity therapy. You give high dose insulin euglycemic therapy, it's called. And then you give calcium chloride, then glucagon. Step 4 is lipid emulsion, and step 5 is ECMO for refractory cardiovascular collapse. So the key takeaway point, again, this is not a randomized controlled trial. They looked at over 100 cases, case series, but calcium channel blocker, beta blocker, overdose, high dose insulin is the cornerstone. And then you add calcium chloride, glucagon, lipid emulsion, and then ECMO for refractory collapse. Don't wait to start insulin. How about opioid overdose? Here we do have a trial. It's published in the New England Journal of Medicine 2023. Fentanyl outlasts naloxone. So you have to use the Narcan again. You start with 2 milligrams of naloxone, not 0.4. And re-narcotization requires infusion. So the standard dose was often insufficiency for high potency synthetic opioids. And so in the New England Journal of Medicine 2023, they talk about the higher dose and has faster reversal for especially those high potency synthetic opioids. Okay, so fentanyl outlasts naloxone. The effective bolus was 4 milligrams. So you run 2.7 milligrams per hour infusion to prevent re-narcotization. That can occur 30 to 90 minutes post-reversal as the naloxone wears off. And you want to confirm that it's the opioid trial. So you want to see pinpoint pupils, respiratory rate less than 12, and alter mental status before you would give the naloxone, which is diagnostic and therapeutic. So we've had that over the years. You give a bolus, calculate 2/3 of that dose per hour, run the IV infusion over 4 to 6 hours minimum, and then you repeat the same bolus. Intranasal versus IV naloxone. So that is 8 milligrams intranasal had a faster reversal in fentanyl overdose versus 4 milligrams intranasal. And okay, so I guess the point is the fentanyl era naloxone, we start with not with 0.4, but we start with 2 milligrams. 2 milligrams, and you repeat every 2 to 3 minutes up to 10 milligrams. And then you infuse at 2/3 of the reversal dose per hour. Observe 4 to 6 hours minimum, and that's how you set up. If you didn't have a toxicology person to call, that's what you would do. And you have to watch out for re-narcotization. And remember, intranasal, 8 milligrams intranasal is faster for the synthetic opioids, fentanyl and carfentanil. So now let's look at the toxidrome serotonin syndrome versus NMS. So this is Dunkley, 2003, but there is Boyer et al., New England Journal of Medicine, 2005, looking at this Hunter criteria that we'll take a look at, which has sensitivity of 84%, specificity of 97%. They look alike, the serotonin syndrome and neuroleptic malignant syndrome. So serotonin syndrome would usually rapid as opposed to neuroleptic, days to weeks. Serotonin hyperreflexia and clonus. Neuroleptic bradyreflexia, ocular clonus, serotonin syndrome, and diarrhea, diaphoresis, mydriasis. Hunter criteria, 84% sensitive, 97% specific. Treatment is cyproheptadine. Here you could see the 5 hyperthermic toxicodromes and their differentiations. This is a whole talk in itself, but basically you see mydriasis, you think of sympathomimetic, anticholinergic, and serotonin. If you see that ocular clonus, you're thinking serotonin syndrome. If you see lead pipe rigidity, you're thinking neuroleptic malignant syndrome. Okay, so you could, take a picture of this slide, but basically serotonin syndrome is rapid onset, clonus, hyperreflexia, and you're going to give cyproheptadine, 12 milligrams, and benzodiazepines. Neuromuscular syndrome is not as rapid, lead pipe rigidity, and no clonus. You stop the antipsychotic and you give dantrolene and bromocriptine, and the Hunter criteria is specific for serotonin syndrome. Okay, and we're almost done. The Weaver, New England Journal of Medicine, 2002. So we're looking at symptomatic carbon monoxide, 152. Should we give them hyperbaric oxygen? It cuts the cognitive sequelae, 25% versus 46%. This is actually, it seems like it's irrelevant, but the truth is, I think this is the number one poison death in America. It's actually carbon monoxide. So hyperbaric oxygen, 3 sessions within 24 hours, the cognitive sequelae at 6 weeks, 25% versus normobaric oxygen, 46%. So this is randomized controlled trial all the way back from 2002. The pulse ox lies, the carbon monoxide and oxyhemoglobin absorb the same wavelength. So you have to use a co-oximetry. Remember that, the oxygen half-life math. Room air, 5 hours, 100%. Oxygen, 60 to 90 minutes. And then if you give hyperbaric oxygen, it will come out in 20 to 30 minutes. So therefore, you want to start the 100% oxygen immediately because the half-life is the key. So once again, room air would take 5 hours, but oxygen would be 60 to 90 minutes, but a hyperbaric would be much faster. The indications include loss of consciousness or any carbon monoxide hemoglobin greater than 25%, cardiac involvement, age greater than 36, you would call a regional hyperbaric oxygen center immediately. Smoke inhalation, you have to treat both CO and CN cyanide as well. You give a cyano kit, 5 grams IV that binds the cyanide, and then it gets excreted by the kidneys. Alternatively, sodium thiosulfate. Do not use nitrites in combined CONCN. Okay, so here's the bottom line. Hyperbaric oxygen cuts the cognitive sequelae. We looked at the half-life math, 25% versus 46%. Pulse ox is unreliable. You have to use the co-oximetry, and 100% oxygen immediately while you're waiting for that hyperbaric oxygen. So some of the 4 more you should know about: organophosphate poisoning, pralidoxime. So, I mean, this is going to be very, this is more for like Army situations, but it could be relevant to us soon. Who knows? Botulism, antitoxin timing, when you would use that for descending paralysis, local anesthetic, systemic toxicity, lipid emulsion. That's what you would use for, let's say, if you use too much lidocaine. And of course, where do we get this fomepizole? For methanol and ethylene glycol poisoning, fomepizole is the antidote because it inhibits alcohol dehydrogenase. But at least we've seen some of the key numbers when it came to GBS. IVIG was better. Myasthenia gravis, thymectomy for minimal, even without a big thymoma, even without a thymoma. 20, 30, 40 rule, we should know. CIWA protocol, ICU admissions, phenobarbital, dropped it. We should know NAC, less than 8 hours. We should know TCA, looking at QRS. We should know calcium channel blocker, overdose, think lipid emulsions, high dose insulin first, and then opioid naloxone, understand how they came up with this infusion dose, and then know the difference between serotonin syndrome and NMS. And that's it. It's a long one.